So when you hear hepatitis E virus, what pops into your head? Probably the textbook version, right? Big waterborne outbreaks in developing nations. Well, I want you to put that idea aside for a moment, because here in the Netherlands, we are dealing with a completely different beast. This is a local story, it's a zoonotic story, and for a very specific group of our patients, it's an incredibly urgent clinical problem. Okay, let's get into it. Right, before we jump in, just a quick note on where this all comes from. We've compiled this information using a Gemini deep search, and if you're the kind of person who likes to dig into the primary literature yourself, we've got you covered. There's a full list of all our sources in the linked Notebook LM document. Here's the game plan for today. We're going to start by telling a tale of two viruses, what the world thinks versus our reality. Then, we'll zero in on the clinical challenge right here in the Netherlands. After that, we'll unpack the virus itself, talk diagnostics, management, and wrap it all up with prevention. It's a straight shot from identifying the problem to finding the solution.
All right, let's kick things off with Section 1, a tale of two viruses. This is all about the global perception versus our local reality. Okay, this slide, this is the core of the entire story. On the left, you've got the hepatitis E virus everyone learns about, genotypes 1 and 2, spreading through contaminated water, causing these huge outbreaks of acute hepatitis. But that's not our story. Here, in the Netherlands, you got to look at the right side. We're dealing with genotype 3. It's foodborne, coming mainly from undercooked pork. And its biggest threat isn't a sudden acute illness in everyone, but a sneaky, persistent, chronic infection in our most vulnerable patients. See? It's like two totally different viruses sharing the same name.
So let's dig into that Dutch side of the story a bit more. This brings us to the clinical challenge here at home, which you can really think of as a silent epidemic.
This quote just nails it. When we look at seroprevalent studies, a whole lot of the Dutch population has antibodies. I mean, a surprising number of people have been exposed to this virus. And yet, we see very, very few actual cases of acute hepatitis. So what gives? It's this iceberg phenomenon. It means the virus is just quietly circulating all around us, in our food chain, causing infections that most people never even notice. The real danger isn't the tip of the iceberg we see. It's what's lurking just below the surface for a very specific group of people.
And this is that group. This is who's in the crosshairs. For the immunocompromised, this silent virus becomes a massive threat. We're talking about solid organ transplant recipients, folks with blood cancers going through chemo, patients with advanced HIV, really anyone on powerful immunosuppressive drugs. For them, their immune system just can't fight it off. It can't clear the virus, and that allows hepatitis E virus to set up shop for the long haul as a chronic infection.
And make no mistake, the consequences are brutal. In these patients, a chronic hepatitis E virus infection is not a slow burn. It's an aggressive fire. It constantly drives liver inflammation and scarring, and it can lead to full-blown cirrhosis in as little as 2 to 5 years. This is not some theoretical might-happen risk. It is a major cause of progressive liver disease in this population, which makes finding it early absolutely critical.
Okay, so we've laid out the clinical problem. Now let's get to know the culprit a little better. Time to unpack the virology of this zoonotic threat. So for the virology buffs out there, here's the formal address. It's in the Hepeviridae family. But the key takeaway for us is that our player, genotype 3, sits right in the species Hepeviridae balayani. This is the group that contains all the major human-infecting genotypes, and it's what separates our virus from its other relatives that stick to different animal hosts.
Now, this is where the virus gets really clever. It has a fantastic survival trick. So when it's shed in stool, it's a naked, non-enveloped virus. But in the bloodstream, it steals a bit of the host's cell membrane and wears it like an invisibility cloak. This quasi-enveloped form hides its viral proteins from our antibodies, letting it travel through the body completely under the radar. It's this dual personality that also makes it a real pain in the lab. Trying to grow genotype 3 in cell culture is notoriously difficult, and it often doesn't even cause visible damage to the cells, which makes isolation a huge challenge.
So, knowing all that about the virus and who's at risk, how do we actually find it? That brings us right to diagnostics and the golden rule, using the right test for the right patient. Okay, this is probably one of the most critical clinical takeaways of the whole explainer.
There is no one-size-fits-all test here. The very first question you have to ask is, what's my patient's immune status? If they're immunocompetent and you suspect acute hepatitis, sure, an IgM serology test is a great place to start. But, and this is a big but, if your patient is immunocompromised, say with mysteriously high liver enzymes, you go straight for the molecular test. An RT-qPCR is the mandatory, non-negotiable first choice, period.
And I am going to say this again because it is that important. If there's one thing you remember from this section, make it this. In an immunocompromised patient, a negative IgM test means absolutely nothing. Their antibody response can be weak, delayed, or just plain absent. Relying on that negative result is a recipe for disaster because you'll miss a treatable chronic infection. In this population, you have to use RT-qPCR.
All right, so you've used the right test and you've confirmed a chronic infection. What's next? How do we treat it? Let's dive into the Dutch and European approach to management. The approach here, which is in line with the European liver guidelines, is actually really elegant. Step 1 isn't a drug at all. The very first thing we try to do is reduce the patient's immunosuppression. You're essentially trying to take the handcuffs off their own immune system and let their T cells do the job. If that doesn't work or it's just not safe to do, then we move to step 2, a 3-month course of ribavirin. Now, it's not without its own challenges. The virus can develop resistance, so you do have to be vigilant.
Now, you might be thinking, wait, that sounds different from what the WHO or CDC says. And you'd be right, but there's a good reason. The WHO and CDC are focused on that other hepatitis E virus, the big, waterborne, epidemic kind. So their advice is all about supportive care and clean water. They're not wrong. They're just solving a different problem. Our guidelines, the ESAL and Dutch ones, are specifically tailored to our challenge, treating chronic genotype 3 in our vulnerable patients.
And a quick, important word on kids. What about them? Well, even though we don't have a ton of large-scale trial data, the guiding principle is exactly the same. For an immunocompromised child with chronic hepatitis E virus, the playbook is identical to the adult one. First, see if you can safely reduce their immunosuppression. If not, ribavirin is the next step.
Okay, last section. We've talked about finding it and treating it. Let's zoom out one last time and talk about the big one. How do we stop people from getting infected in the first place?
Since this is a foodborne issue, prevention really boils down to what happens in the kitchen. The number one rule is food safety. Cook your pork, your wild boar, your venison all the way through. That's what it takes to kill the virus. And for our high-risk patients, the advice has to be even stricter. They should just avoid undercooked pork, game, and even shellfish altogether. And the real kicker? Unlike hepatitis A and B, we have no vaccine in Europe to help us out.
Which leaves us with this final thought to chew on. We know the virus is in our food, we know exactly who is most vulnerable, and we know our main prevention tool is just telling people to cook their meat properly. So the real question for all of us is, what's next? What's the next big public health step we need to take to truly protect these patients?
And that's a wrap on our look at the Dutch paradigm for hepatitis E virus. I really hope you found this useful. Do us a favor and subscribe to the channel for more explainers like this one, and we'd genuinely love to hear your questions and thoughts down in the comments. Thanks for tuning in.